everyone. Welcome to Webinar Wednesdays with Can Do Multiple Sclerosis. My name is Haley Van Wagenen, and I will be your moderator for today. And our topic is bringing MS vision problems into focus. So thank you for being here. I want to take a brief moment to thank our generous sponsors for supporting this year's webinar series. Thank you to EMD Serono, Genentech, Sanofi, Viatris, and Zanus. And I would love to introduce our speakers. Tonight we are joined by neurologist Gabriel Pardo and Kristen Shiflett, who is an occupational therapist who specializes in low vision. So thank you guys for being here, and I will hand it over to Dr. Pardo.
Well, good evening, Haley, and good evening, everybody. It's a pleasure to be here tonight and to address this very important topic of vision and multiple sclerosis. And it is very important because, as many of you probably have experienced, visual manifestations in multiple sclerosis are quite common. And there are some very specific reasons for that. As you all know, the nature of multiple sclerosis is that we have these inflammatory events in the brain and the spinal cord secondary to an abnormal activity of the immune system that result in damage to certain aspects, components, areas of the brain and the spinal cord. Those areas that are being affected can happen randomly as it pertains to time. We do not know when they would happen, but also randomly as it pertains to location. Any part of the brain, any part of the spinal cord can actually be affected by these episodes of inflammation and damage. And the manifestations in MS are secondary to those processes. So it stands to reason that if the visual system actually represents a significant proportion of the amount of brain, then areas that are involved with vision can commonly be affected by the process of multiple sclerosis. As a matter of fact, over 50% of the brain is related in some way to the visual system. So that highlights the fact that indeed it will be very common for you to be able to have manifestations in your eye and your vision secondary to multiple sclerosis. When your eyes are open, vision itself is going to be responsible for 66% of the brain's electrical activity. That accounts for 2 billion of the 3 billion electrical firings per second that take place in your brain. Your brain is always doing stuff, as you can see here. As a further example of how important the visual system is, we can talk about the structural hierarchy. And by that, I mean, if you think about the auditory nerve, that is the nerve that sends information from your ear to your brain so you can hear, that auditory nerve is made up by 30,000 axons or 30,000 individual nerve cells. That is quite a lot. But if we think about the optic nerve, it is 1.2 million nerve cells. Again, that gives you a proportion of how important the visual system is for us as human species and how, because of that representation in the brain, that we can see significant amount of manifestations in diseases like multiple sclerosis that can affect multiple different locations. Next slide. When we then look at how to understand the problems with vision in multiple sclerosis, it's best if we separate these in 3 basic categories. Because the visual system is not just what we think about, just sending information to our brain so that we can see. And we're going to divide then the understanding of this by looking at the information that goes in to the brain from the eyeballs into the brain, the information that comes out from the brain to the eyes, specifically for the movement of the eyes, which is a very complex process, but also a very additionally important process that takes place in the brain, which is coordination and integration of the information that takes place. Next slide. So when we talk about the in system, this is the system that allows us to see images. We call this technically the afferent system. Afferent just means it's sending information in towards the brain. And it's composed by different aspects that start all the way in the eyeball itself, in the back of the eye. We have this structure called the retina. Many of you are familiar with that term. And the retina is actually, even though it sits inside the eyeball, it is part of the central nervous system. It is part of the brain. Actually, we think about it from an embryological perspective. When a baby is developing, that part of the eye, the retina, the back of the eye, actually comes as projections from the frontal part of the brain, little pedicles that come out and join the eye and conform that posterior aspect of the eyeball itself. So the retina is part of the brain in that regard, and that is where the afferent system starts. The retina is going to capture the information that is sent to us as light and transform that into electrical impulses. And it does so in a layer of the retina called the photoreceptors. Those are the cells that are going to make that transition between light and electricity. And once we have that as an electrical signal, it's going to send it back into the brain initially through the optic nerves. And you see in this diagram to the right, you see the eyeballs in front, and then you see those little channels that kind of come from the back of the eye towards the brain. Those are the optic nerves. The optic nerves eventually are going to get inside the skull and be part of the brain structure overall. And they're going to join in a structure called the chiasm, which is that X that you see there. And at that point in time, half of the information from one eye is going to cross over to the opposite side. And of course, the other eye will do the same thing. And from there back, we have what we call the visual pathways, in the sense that we have the radiations that fan out. You see that fanning out of those nerve cells, and they're going to go through large portions of the brain, the temporal lobes, the parietal lobes, and finally reaching the back of the brain, where we have what we call the occipital cortex. And it's in the back of the brain where we actually see, where we can interpret the images and we're able to see. So again, a lot of territory, a lot of area occupied in the brain, amenable to be affected by damage from multiple sclerosis. Next slide. So what happens with that system when it doesn't work? So malfunction of the in system can be manifested by decreased vision. We have blurred vision, and we can differentiate if you have a problem with the acuity, the sharpness with which we can see images, or do we have problems with contrast, or do we have problems with color. We can actually have significant decreased vision to the point that we can lose vision completely. But we can also have something different, and it's not the loss of the quality of the central vision, but the loss of the visual fields. How far out can we see when we're looking straight ahead? Next slide. So one of the examples, and perhaps the most common one, is the case of optic neuritis. And optic neuritis refers to the fact that the optic nerve, that very first structure that starts from the eyeball and goes back into the brain, can be affected by multiple sclerosis, can be the subject of the inflammation and damage that takes place in MS. As a matter of fact, 20% of the patients that are eventually diagnosed with multiple sclerosis will have optic neuritis as the very first manifestation. This is the first thing that they notice. This is almost a fourth of the people with multiple sclerosis. Now, as we follow people over time through their journey with multiple sclerosis, up to 0.5% of all of you with MS will have had an episode of optic neuritis. Sometimes it is subclinical, meaning that you might not have all the manifestations, but we will be able to identify that as we examine you. Even more relevant here is the fact that when we do post-mortem studies, when studies have been done in people that have passed away with multiple sclerosis and they donate their brain, they donate their eyes for us to study them, it has been identified that even though as you are alive, only half of them will have optic neuritis. Actually, up to 95% of the people with MS will have evidence of damage of the optic nerve secondary to multiple sclerosis. So it's a very common location to have problems with MS. And we can divide the optic neuritis of inflammation of the optic nerve according to the location in the nerve. Is it towards the front part of the nerve? Is it to the middle or the posterior part? Is it happen only in one eye? Does it happen in both eyes, one first, the other one second? So we can give a lot of last names to the optic neuritis to classify it better. But many of you will have experienced that episode of optic neuritis characterized by having a little bit of blurred vision that over hours or days actually continues to worsen and will affect your perception of colors, the quality of your vision, and will be associated very commonly with pain behind the eye, especially when you move your eye to the right or to the left, you feel this deep ache behind the eye. That will be a classic presentation of optic neuritis. And classically in MS, you will have some degree of recovery, many times significant recovery, but unfortunately, and this is the concern that we have in multiple sclerosis, you might be left with some degree of deficit, an incomplete recovery, and this is how we start accumulating deficits in MS, and we would like, of course, to prevent that. Next slide. So I mentioned how with optic neuritis, you will have problems with visual acuity. You will have decreased perception of color. Colors look washed out. You can have problems with the visual fields that I'll explain in a second. You can also have what we call positive visual phenomena. That is a fancy way to say that sometimes you can perceive flashes of lights or some geometrical figures in your vision. And later on, many of you that have had optic neuritis might experience this one fancy term that is the last one here on the list called UTOFs. UTOFs refers to a process during which an optic nerve that has improved the function, meaning you have regained some quality of vision under certain circumstances, the most common one of which is increased body temperature, either because you get hot through exercise or a hot shower or having a fever, will notice a decline of the quality of vision. And you think at that time, oh my God, I'm having another episode of optic neuritis. But different from optic neuritis, as soon as your body temperature normalizes, the symptoms go away. That is a very common process that happens in people after they have had optic neuritis. Next slide. This is an example of an MRI showing an inflamed optic nerve. So in the MRI to the left, you see the eyeballs in front, and then on the right-hand side, you see how the optic nerve appears very white, very bright. That is because it's picking up the contrast material because it's diffusely inflamed. Likewise, on the right-hand side, you have the orbits. This is a view of the back of the eye, the sockets. And on the right-hand side, you see that in the center of what are the muscles that appear like these ovoid structures that are bright, the optic nerve also appears very bright. Again, a way to identify inflammation of the optic nerve, even though we have a lot of other ways to do this. Actually, before we do an MRI, and when we see you in the examining room, we'll be able to tell if you have optic neuritis just by our examination alone. Next slide. Now, we can have problems not of the optic nerve, but at the level of the chiasm, which is that structure where we have the X, where we have the crossing of information, or beyond on the visual pathways where it fans out. And again, those areas can be affected by multiple sclerosis. So if you have problems in those locations, you will have probably not necessarily decreased visual acuity, but more of a visual field deficit. And in the next slide, I'll show you briefly the variety of possibilities that you see right here, depending on the location, and you see how they are numbered on the right, 1 through 9. And then if you go to the left and you cannot find those numbers in the pathways themselves, depending on where an MS lesion is located or any insults to those areas through other processes, that you can have different types of visual field deficits. So on the right-hand side, you have the description or the depiction of the visual fields as anybody will see them, their environment in front of them, and the dark areas are areas that you do not see well through or cannot see at all. So you can see there's a whole variety of manifestations. But if you look, for example, at number 5, you see that those individuals do not have the ability to see half of the visual field horizontal midline to the left in this case. And that happens when we have involvement of the visual pathways behind the chiasm. And this is important to differentiate during an exam because many people will come to us and say, I cannot see out of my left eye because they are not perceiving things to the left of the visual field. And that might make us think that you have a problem with the optic nerve on the left side, or maybe a problem with your eyeball on the left, but in reality, it's not the eyeball, it's not the optic nerve, but it is farther back in the brain, and it's not just your left eye not seeing, it's both eyes not seeing well to the left. All this to say that whenever you have visual problems, that certainly a good examination is going to be paramount for us to understand what type of problem we're dealing with, what is the location of the problem, and of course, what do we need to do about it. Next slide. This is an example of an MRI, just a bright area inside the brain, very small, but properly located to create one of those type of visual field deficits, not necessarily in the eyeball or the optic nerve, but still having a manifestation in your vision. Next slide. Now, let's talk briefly about the out system, so the system that controls your eye movements. We do not give eye movements a second thought. They happen naturally, but it represents a very, very complex process. If you think about it briefly, when you look to your right, when you move your eyeballs to the right, your right eye is moving out, but your left eye is moving in. And these movements are done by different muscles, of course, on opposite sides, and commanded by different nerves, and instructed to do so by different parts of the central nervous system. So the process has to be coordinated so that whenever I move my right eye to the right, my left eye follows in the same direction, at the same speed, and the same amount. And again, that is not an easy process. That process is controlled essentially by different nuclei or centers of control located in the brain stem, and we call those the nuclei of the third, the fourth, and the sixth cranial nerves. And if we have problems there, we'll have problems with movement of the eyes, but we can also have problems with the communication between those command centers. If they're not telling each other what is happening, they cannot follow. And then we can have problems with the cranial nerves themselves. Next slide, and I'll show you an example of what that might be. These are the results of these sort of problems. When your eyes are not aligned properly and when they're moving, then you can have double vision because the eyes have to be positioned properly to avoid that. Sometimes we have problems with control of the eyes, and they have this uncontrollable movement called nystagmus. It's a little jerky movement of the eyes. It can be in many different directions, but your perception as a patient with nystagmus is what we call oscillopsia. Oscillopsia is a fancy term to say that when you're looking at something, things appear to be jittery, they're moving, and that is because your eyes are not staying still. Sometimes we have other conditions, less common, something called saccadic intrusions, where your eye will suddenly make a jerky movement, and then you can, for example, lose your place when you're reading, things of that nature. Next slide. So the efferent system can have all these different types of manifestations, the most common one of which, the one that I'm going to talk a little bit in more detail, is called an INO. And perhaps many of you have been diagnosed with an INO. That stands for internuclear ophthalmoplegia. Again, a mouthful, but just to say that ophthalmoplegia means your eyes are not moving properly. Internuclear, the source of that is between two of the control centers that move your eyes. Next slide. And here you find the depiction of that. So in the left-hand side, you see your left eye and your right eye. They're supposed to move to the right. The right eye does so by the command of the sixth cranial nerve, which is the little purple ovoid located in the brain stem, and that is what that little trunk structure is in yellow. But when it does so, it has to send a signal to the opposite side, the third nerve that is farther up in the brain stem and on the opposite side, so that the left eye also moves along. And it does so through a little communication pathway, a little highway called the MLF. And this is an area that is very sensitive to being affected by multiple sclerosis. And when we have lesions right there, then your left eye will not follow. Your right eye will go to the right, the left eye will be left behind, and that will create double vision. Next slide. And the last component is the process of integration. And it's the fact that not only we have to have good quality of vision and the capacity of seeing, but that we need to integrate all this information so that we can understand what's going on. That is what allows us to detect motion, to identify shapes, to gauge a distance and the speed of an object, judge sizes, be able to see in three-dimensional view. The brain also fills in blind spots. You can have areas of a visual field where you cannot see, and your brain by default will fill that in and it will complete an image. It can correct distortions. It can do a lot of different things. And importantly, it can also associate vision with emotions. And all those are integration of the visual system with other parts of the brain responsible for those type of processes. Next slide. And some of the problems when we have the malfunction of the integration system is something that we call apraxias and agnosias. Again, fancy terms just to say that apraxia is a limitation of the ability to move your eyes voluntarily despite the ability to do so. You don't have any dysfunction in the system that moves your eyes, but you cannot voluntarily move your eyes. And agnosias refer to a neurological condition where individuals will have difficulty recognizing objects, faces, or even colors, despite having normal or near normal vision. Perhaps one of the most common types of agnosias, and you probably have heard about this, is something called prosopagnosia, where people cannot recognize faces. They will see someone that's familiar to them and they do not know who they are just by looking at their face. If they speak and they hear their voice, sure, they know who they are. Some famous people have acknowledged that they have prosopagnosia. For example, Brad Pitt has come out and said that he has this difficulty in recognizing faces. Next slide. This is a little bit of insight into the process of MS, because indeed, as I have been talking about, the significant representation of the vision in the brain and the ability of MS to affect multiple areas of the brain will make the vision being a big window into the soul of multiple sclerosis. We rely on a detailed visual examination to be able to understand many of the problems that are happening in multiple sclerosis. And of course, we are prepared to try and compensate for those deficits if they happen to be present. And that brings us to the second part of the talk, which is more hands-on about what are these problems, what can we do about them, and for that we have the great opportunity to hear Kristen instruct us on those pieces of information.
Thank you, Dr. Pardo. Hello, everyone. My name is Kristen Shiflett. I'm an occupational therapist. I work at the Wilmer Eye Institute in Baltimore, Maryland. So just like Dr. Pardo said, you had the diagnosis of MS, and you're trying to learn the medical capacities and what you need to know about that. But the big thing is you also have to live, right? We still, even though we hope for cures, we have symptoms that really impact our everyday lives. And that's what the low vision clinic does, and we focus purely on function. So we take your vision, what you present at that day, and try to find solutions. So think of like your good MS days, your bad MS days. We would try to see how the vision impacts your ability to function. So the first person you would see, you can get a referral from your neuro-ophthalmologist, a primary care doctor. There is a website called Vision Aware. It is with APH, was the American Printing House. You can go to that website. There's a lot of resources on being visually impaired, but it also has a lot of great resources of people in your area that can help you. And so we'll make sure that you guys have that link after this talk, just for future reference. So if you see a low vision optometrist, so they specialize in low vision, basically they're going to give you a really good eye examination. They're going to look at your visual acuity, looking at distance, so how big or small the letters you see at the distance. How well you see things up close at near. And near, we say, is about 16 inches. So really like when you're bending your elbows naturally is probably where the distance is that we test. The other things like Dr. Pardo was talking about was visual field confrontations. So, we'll have patients cover an eye, like on this bottom picture here in the middle. The examiner, the person being examined, is covering one eye, and the doctor is moving their fingers and wiggling, trying to see what they detect in the sides of each of the eyes. And then also we'll have people just to see what they can see from their side vision. And then we'll look at anything that's impaired in the center part of their vision. That's usually with a reading test, but also we'll look at faces as well and say, like, does anything look different to my face? Is some part of my eye missing, or my mouth missing, or something's blurry or fuzzy? The other thing we test, and actually our clinic tests this, is the contrast sensitivity. We're going to go over that in a minute and define what that is. But that does purely impact function, and that's one of the big points of my talk today. The last thing that the doctor does, which everyone asks whenever they see an optometrist, is what can glasses do for me? And so people typically come in with complaints of blurry vision. They want glasses. If you have any deficits in these areas, that's impacting the anatomy of your eye. So refraction of glasses is going to do a small portion of it. And we'll go over other things that will help with your vision. So glasses solely can't usually solve the problem. It's usually glasses and something else. So go ahead, next slide, please. So the big thing that we actually measure in the low vision clinic is contrast sensitivity, and that is the ability to distinguish an object from its background. So the chart to the right has dark letters in the beginning and it fades. And yes, there are letters on the bottom 2 rows. So basically, this is allowing you to see how much contrast you need in order to detect those edges, to be accurate with your movements. And so that's a very important measure that not all the clinics look at. And we'll again go in more detail here. And also, people do have trouble with letters and recognizing them due to other issues. We do have on the bottom there, it says called Hiding Heidi. And so she's nice and bright black on the left side, and it fades to a very faint gray on the right. Next slide. So how contrast really impacts function. So the big one, everyone usually comes into our clinic is like, I'm having trouble reading. I can't see that quality of the print. That newspaper looks faded. And so that's one of the first signs that they usually come into our clinic with an issue. The second one is mobility. So the ability to detect curbs, hazards. So they're walking along, they tripped over something that kind of blended in together. Outside on curbs and steps. The curbs, like on the bottom picture here on the right, there's 2 pictures of stairs. On the left is normal vision, so you can see each individual step. On the right, it has someone that has impaired contrast sensitivity, and it just like it's a big sheet of paper. You can't see that definition, so it really impacts your ability to safely function and go up and down stairs. Also, again, facial recognition, that's a really big deal, very important for our society to communicate with each other. And then also some of the basic things like seeing food on your plate. So on the top plate, there's 2 pictures of food. On the left-hand side, there's mashed potatoes on a white plate, which is very hard to see. And then on the right side, there is meat on a dark plate, which again is very hard to see. So if we flip those 2 and have the mashed potatoes on the dark plate and the meat on the light plate, that would give you more contrast. So that would help things stand out a little bit more. And also the other big thing also is driving. A lot of people say they have trouble seeing in overcast days. It's just a little bit difficult to see the signs. And so again, that's where contrast sensitivity can impact function. Next slide. So again, the research kind of supports this importance of contrast sensitivity. So contrast sensitivity, rather than visual acuity, can be a stronger indicator for falls. And that is very true. Again, we talked about those steps before. Poor contrast sensitivity has been independently associated with a slower gait speed, shorter stride length, wider step width, increased time. And that is a big deal because, again, with MS, you're not only focusing on your vision, but you have to coordinate things. You have to coordinate that cane or walker if you need it. And if you don't have really good contrast sensitivity, it makes it harder for you to learn the techniques you do, whether it's in physical therapy, occupational therapy, speech therapy, to function. And so basically, also they've noticed that impaired visual acuity and contrast can negatively impact someone's cognitive ability, social engagement, physical activity, physical independence, and overall quality of life. And again, from those examples before, it kind of, again, makes sense. If you're not seeing someone's face, you're not going to really confident into talking to someone if you can't know who they are. And so this really can impact your overall quality of life. Next slide. So another issue, another thing that we look at in the clinic is glare. Glare sensitivity is a big deal, especially for those patients that have MS, that have optic neuritis. Again, those inflamed areas of your eye and brain that just make it very hard to function. So pictures on the right bottom here, you can see where the different types of glare. You can have glare where it's very fuzzy and blurry. You can have that halo effect or even starburst. And so basically glare, when we have difficulty with that, we really kind of squint our eyes, which can be straining and be very uncomfortable. A lot of my patients tell me they have headaches. And so some of that could be because of the glare. And glare could be indoor or it can be outdoor. And so basically we want everyone to be comfortable with their everyday activities with the lighting, because again, we need lighting for increased contrast. So lighting can be very helpful for us, but also can be the nemesis as well. So we want to think of different ways to make it easier for ourselves. A lot of the patients talk about, again, the glare, make it difficulty with walking. Looking around things in the kitchen can be difficult, but mainly a lot of people also talk about going outside. So if they have a lot of glare, it's really hard at grocery stores or at work because of those fluorescent lightings. It makes it very difficult for people to function. Next slide. So basically all these things that we've talked about, again, you would see the low vision optometrist, and they would, again, assess your overall functional needs. They would establish some goals. Like each patient has different goals. Not everyone is the same. MS affects everyone differently. Same thing for the eyes. And so we definitely want to give a very comprehensive evaluation. So we are referred, so then you can refer to an occupational therapist like myself. And again, we focus on everyday functioning. So things that you do every day from the moment you get up, the moment you go to bed. And so basically we can figure out ways to optimize your function, increase your functional reserve. And what I mean by functional reserve is, we wake up with a certain amount of energy, and how much energy, as we learned from Dr. Pardo, that our eyes provide us. And we want to maintain that energy as long as we can. So people with vision impairment, whether it's MS or macular degeneration or glaucoma or any reason, that visual functional reserve depletes very quickly, because you're trying to do things, try to be independent as possible. So it's really tricky to do. And so we try to increase that functional reserve. So we do that with looking at different strategizing for strategizing for optimizing your function. And so maybe looking some optical devices, some glasses and things like that. So every person's different. We try to create your own plan. So next slide, please. So basically, one of the first things we look at, like I talked about, is lighting. Lighting is throughout indoors and our surfaces. So it could be like in the kitchen, you see there's overhead lights here. I'm a big fan of dimmers because depending on how your day is and how bright it is outside, you can dim those lights if you need to, or brighten them up if you need to in the room, depending on how the environment looks. We just don't want to have pockets of darkness. And also, for a lot of my patients with optic neuritis, I don't want you to live in darkness. As soon as you come outside, you're going to be overwhelmed with light by the outside. So definitely having dimmers provides you a little bit of flexibility. And then also you can have dimmers up top. Under counter lights are helpful too. There's different colors of light. You can have the soft white, which you'll see in the bottom middle here, bottom right. There's soft white, there's bright white, there's daylight. So they have different types of tones. A lot of my patients with optic neuritis do like the cool tone. Just it makes it a little bit easier on their eyes and a little more comfortable to function. Next slide. Again, we talk about task lighting. So task lighting is another way to avoid glare because you have it low and direct on what you're looking at. So the person in the bottom picture is working on a piece of paper. That light is positioned low. It's positioned between the person and the paper. And then you can have that flexible gooseneck. And these are a couple examples that can make it easier for functioning. Next slide. Again, safety, stairs are a big deal, just like we talked about, trying to coordinate steps, coordinate your movements, where your foot placement is. Safety is a big deal. So obviously handrails, you want good quality of steps. If your steps, the carpet is rubbing up, that's not safe, trying to get them readjusted so they can be nice and clean, easier for you to make steps. A lot of my patients also add lighting to the steps, like that bottom left picture. So they're motion sensors. As you go down, it lights up. The other thing we do is use duct tape, high contrasting colors. So I had a patient in Baltimore City. These are her stairs on the top left. They're all white and it's swirled around. And so basically I put black tape on where she had to make her first 2 steps. So once we know where the first 2 steps, you can continue to go around and go up the stairs. So the first 2 and the bottom 2 are usually the ones we mark with tape, and depending on the surface. Also, there are some on the bottom right here, it's black and yellow. So that's caution tape, and it's actually a little rough too. So you also could feel where that is on your foot too. So these are some examples of stairs that I've done in the city. Next, please. Another way for indoor glare in overcast days is using filters. So there are different types of companies out there that have filter glasses. And the big thing you want is a wraparound effect. So you want the glasses to wrap around your eyes to prevent any light from coming in from the top or the sides or the bottom. They each have different kinds of colors. So this one here to give contrast enhancing, a yellow color is very helpful to help with decreasing those starbursts, decreasing that glare. And so you'll be able to see more of people's faces and when you're walking. So it does help with glare for the inside and overcast days. Next slide. The other type some people like for indoors is this purple, or purple pink, I should say. The common one is FL41. So it helps with relief of fluorescent lights and migraines. Again, that wraparound effect. But the one thing I just wanted to point out here is that these examples on the slide, so FL41, the other color is the 88. And then, ironically, the 88 and these 2 bottom examples are from 2 different companies. So just be mindful when you are purchasing some filters, if it's from, Amazon or your local store, just be mindful and know that not every color is exactly the same. And so just need to be mindful when purchasing them. Next slide. So another big thing along with technology is really one way to save energy and fatigue with your eyes is putting not only those contrasting glasses we talked about, but as we call it, going to the dark side. So what I mean by that is inverting your screens, your technology, whether it's a phone, whether it's a Kindle Fire, a tablet, anything for reading. There is a dark mode, and it's becoming more popular to use. Some people use it for just because it looks better to them, but for a lot of my patients with MS, they do enjoy this feature because it calms, it relaxes the eyes, and they're able to work longer and read longer using this. And they also feel like their reading is more accurate. And like I said, it's more comfortable, less eye strain using the black background with white letters. Next slide. So you can have this setting in your iPhone or Android. I'm going to go over both real quick. So the iPhone, again, you can go into settings, display and brightness and dark mode. So again, you can have that all the time with the black background, white letters. If you're not sure when you want that on all the time, there is an accessibility shortcut, which allows you to triple click the side button 3 times and it would switch from white to black, and then click it 3 times again, going from black to white. Next slide. Also, what's on every iPhone, there is something called a magnifier app. If you go to the back library, type in magnifier, it should pop up. So what this is helpful for is that in the far left side, I took a picture of a menu. Using the app, I captured the image, and then you can use the little microphone that's in the middle to zoom in and zoom out if you want. But then also a new feature with the iPhone is that if you hit the reader button, which is to the right of the yellow close button, what happens is that it can change everything to the black background, white letters, and make it nice and clear, which is what in the middle slide is. If your eyes are really tired, you're like, I've had it, I have a headache, a migraine, you can hit listen, and then, or sorry, hit the big A, little a, then hit listen, and it would read everything for you. So this would be helpful for the grocery store, menus, reading your mail. This is basically like an electronic reader and very small and available in your phone. Next slide. So the Android version, just letting you know, the settings display, there is dark theme. And then also you have accessibility button. It's the one in the middle there that's like green and half green, half white. It's under accessibility, color and motion. It's called color inversion. So this button you would touch and it would turn it black and white, just like the other button does on the accessibility button does on the iPhone. Next slide. A big magnifier that we like here is called WeZoom. But then also there is one, an Android magnifier that is recently built in. And this does the same features we talked about with the iPhone. Can take a picture, change the colors, zoom in. So again, help with any reading on the go. Next slide. More in depth that we go to in the clinic is if, these are the basic things we start with the black background, white letters. There's a lot of other solutions that can help. Unfortunately, not a lot of these are covered by insurance, but we do have some availability to get funds if needed. But they're electronic magnifiers, readers, come in portable or desktop versions. So when you see your occupational therapist in the low vision clinic, this is something we'd go over. There's about 32 ways for reading, from a pair of glasses to someone reading to you. So our job is to figure out what works best for you. Next slide. And the last thing, this is the coolest thing that has come out. A lot of people talk about fatigue. Visual fatigue is huge just as well. And so this is something new come out called Meta. Yes, it's by Facebook, Instagram, Meta. But basically it's smart glasses. There are cameras on the sides of each of the temples. And then there's a speaker on the side by the ear. And basically with the glasses, you can have it used as AirPods or any Bluetooth headset to answer phone calls, send text messages, things like that. But the biggest thing for the vision part is that it could take a picture of something and tell you what it is. It could take a picture of something and read it to you. So questions we ask all the time is, what am I looking at? Can you read this to me? And it would read it back to you and you would hear it in your ear. And the volume can be high or low depending on what you need. It's even gone to the point I took a picture of my refrigerator and said, where's the ranch dressing? And it said on the top left. Is this banana rotten? No, there's a couple brown spots on it, but it looks ripe and ready. So it's, again, amazing what this technology can do. It's a very low cost, only $300 compared to what other vision devices can be, like thousands of dollars. So just want to let you guys know of this great technology that's come out that has really been amazing. So I know I could talk about low vision forever. I know you guys have questions. So I'm going to hand it back over to Haley, and here we go.
Awesome. Thank you so much. That was so much information. It was wonderful. And if Kristen and Gabe, you'd like to get back on the screen, I do have some questions that have been asked for you guys. The first one, this one is for Dr. Pardo. What does CNS on your first slide stand for?
Central nervous system. And, central nervous system implies that we're talking about the optic nerves, the brain, the brainstem, and the spinal cord. That is what constitutes the central nervous system. And all of that is the substrate where MS can create damage. The process of MS does not affect what we call the peripheral nervous system. So that's the two big divisions, central and peripheral. And MS does not affect the peripheral one, which is the nerves that come out of your spine into your body itself.
Awesome. Thank you for clarifying that.
Yes.
Next, we have, do you need an MRI to determine if your vision problems are MS related?
So an MRI can certainly help, and it's a very useful tool in multiple sclerosis. For optic neuritis, it is usually not necessary, even though it is used commonly, because when you have episodes of optic neuritis and we can, in the examining room, identify that you have a problem with the optic nerve, and we suspect it is MS, we might want to rule out other causes of damage to the optic nerve. You can have, for example, a tumor or a mass or inflammatory processes in the orbit, in the socket, not related to the optic nerve, and then we would like to exclude that. But if we talk beyond the optic nerve and the brain itself, as I explained, the visual pathways occupy very large portions of the brain. And when we have certain deficits, certainly the MRI will be useful in understanding the location and the extent of the damage that is taking place.
Okay. This one does kind of go off of that question, so I'll put it next to it. How can you tell which vision issues are caused by MS and which ones are just from normal aging?
The $1,000,000 question, right? Because it applies to so many different things in multiple sclerosis. As we age, there are a lot of changes that can take place. And certainly that is the case with vision, because we want to be mindful of the fact that MS can manifest itself with changes in the vision. We do not want to miss the boat on changes that need to be acted upon to prevent any more problems with MS. But at the same time, with your eyes, same with everything else, we need to make sure that people with MS are being evaluated for other possible sources of their problems, and not everything gets blamed on MS, right? And the eyes, of course, can have a lot of different problems, from what we call refractive errors, meaning do you need glasses? Do you have myopia or nearsightedness or farsightedness or astigmatism? Are you developing problems in your lens causing cataracts? Are you having problems in your retina, macular degeneration, retinal detachments? Are you have other conditions like glaucoma that can cause significant problems with the visual fields? So all of that certainly needs to be determined and excluded, and that will be the result of a good exam by the eye care professionals, of whom we have plenty, and they're very, very good at identifying the different sources of the visual problems.
Thank you. Next we have, can halos in vision be a reaction to overdoing it with MS?
Kristen, you want to take that one?
Sure. I would say initially no. Again, halos goes into that glare sensitivity. So talking about those contrasting glasses that we were talking about, different colors can help with that, and try to see if that would help alleviate the symptoms.
Awesome. Next question. Regarding the wraparound glasses, how do you make them work with a prescription lens to reduce distortion?
Very good question. So the wraparound glasses, they typically, what I tell people is to find the color you like and to determine, like, okay, how many times a day am I using this, if that would help with the prescription. They do have them like a fit over. One of the slides, I think, one of the purple lenses, it was literally a fit over. So you can wear your glasses and then wear the fit overs literally over your glasses, and that would give you that wraparound effect. If you're wearing them all the time, like I do have a lot of patients that have like the light purple, and they don't have them super dark, but they're a little light, and it's calming for inside, and then they would switch glasses for outside. You can get specialized prescriptions. You can talk to your optical shop and see what they can do as far as matching a tint, or go and see the low vision optometrist. And we work with lots of different companies to get that prescription and the tint together.
Awesome. Thank you, Kristen.
Yeah.
Is there a link between MS and glaucoma?
So there is no direct link between the two, in the sense that one does not condition the other, but both can affect the same structure, which is the optic nerve. So glaucoma, which comes in two flavors, so to speak, what we call acute angle and open angle glaucoma, The second one being the most common one that actually does not give you any symptoms. You do not feel anything wrong with the eye. There's no pain, there's no redness, it doesn't itch, but you're losing visual fields slowly over time, is a consequence of increased pressure inside the eye. And that increased pressure inside the eye results in damage to the optic nerve. Now, the optic nerve is the same one that is being affected with optic neuritis in multiple sclerosis. So one doesn't condition the other, but someone can have both. As I tell my patients sometimes, unfortunately, you can have ticks and fleas. And the fact that you have one does not exclude the possibility of having the other.
Awesome. Thank you. So much good information. I'm learning a lot. Also, this one is probably for you, Kristen. Why are the bottom steps the hardest to distinguish and often tripped over?
Yeah, so I mean, the part of it could be a couple of things. Again, the same pattern is keep going down. It's usually the bottom two, again, because it's the transition. It's hard to know. Again, it's that contrast kind of blending in together. Because you don't know once you get started, then you know you keep going and you count steps and you get to the top, and then you can like, okay, this is the end. But with the bottom, it just feels like that's where everyone either they're quick to move. It could be their visual field. They're missing that part of the vision. Again, there's multiple reasons why that is the case. It also could be a coordination, fatigue. You're not paying attention because you're like, oh, this is the last step. I'm ready to go. But really a lot of it is the contrast and everything just blending in together. So it's important to have that light, the marking of the steps. And then, like I said, a lot of people count them just to make sure they get down to the bottom.
Makes sense. Next, we have, how often should one have an eye exam with a neuro-ophthalmologist? Are routine eye screenings with a regular eye doctor enough?
So, certainly a neuro-ophthalmologist brings a little bit of a different level of expertise to the assessment of eyes that have some of these manifestations that we've been talking about. But these are issues that well-trained optometrists or a general ophthalmologist will be able to identify. If they feel like it's a little bit out of their area of expertise, then they will make the referral to the neuro-ophthalmologist. Now, if you have had some of these manifestations, if you have an internuclear ophthalmoplegia, I just like to say that because it sounds fancy, but just the movement of the eye problems, or if you have had previous optic neuritis and you already have established care with a neuro-ophthalmologist, of course, it's always good to continue to see the same type of provider so that you can assess for any interval changes, right? Switching providers frequently might take away that ability for us to assess for changes. And remember, in MS, one of the things that we're doing all the time is making sure that you have not developed new problems or worsening of the established problems, because those are actionable items. This is what we can change with our current therapies in MS, is reducing the risk of new manifestations. But we need to be in the lookout for new manifestations. If we ignore them, we do not know when we need to do something different about the management of your disease. So there is an advantage about that. Certainly a higher level of expertise is always welcome, and seeing the same provider, if possible, will again allow us to keep an eye on those potential changes over time.
Awesome. Thank you for clarifying that. My next question is, this one was asked a few times. How does the orange light help?
So I'm assuming they're talking about the contrast. So,
I think so.
with the contrast with the different color filters. So filters come in different colors, and they allow a certain amount of light to come in. So literally there are probably, I don't know, 50, 60 different colors, different shades. And so basically those yellow glasses are allowing more light in and making it brighter so you can see things a little bit more clear. So it's contrast enhancing.
Awesome. Thank you. I know you did touch on this earlier, Kristen, about finding a low vision specialist in your area. Did you want to go into a little bit more detail about that? It looks like a few people have asked kind of how to find somebody in their area. And
Absolutely.
there was another one on asking how to find a good eye doctor that will give you a thorough exam with your MS in mind.
Well, at least with the low vision. So again, remember the neuro-ophthalmology is looking at the health of the eye, and then low vision optometry is looking at your function. So what you do throughout your everyday using your current vision and trying to make the best of it with your everyday activities. So Vision Aware is where there is a database where it has good information about, having low vision, being visually impaired. And then also, it also has a list of providers in your area. So low vision optometrists, there are not a lot of them. Unfortunately, we're trying to get more and more. And there's, hate to say it, even less low vision occupational therapists. There are a lot of occupational therapists in different levels of care throughout the country, but low vision is a specialty. It's additional certification, additional education. So it can be a little tricky to find us, but Vision Aware does a really good job in helping you find that direct to have those options.
Awesome. And just so everyone knows, we will link that in the follow-up email and with the recording of this, just because it has been asked a lot to repeat that website that you had talked about. So we will link that for you so you have easy accessibility to it. And with that, that was the last question of our Q&A. So thank you guys for all of your expertise and answering all of those questions. I will just go over a couple more things. So this webinar is over, but we hope you stay connected with us. If you follow us on social media for the latest programs, resource, and MS news, you can also register for our monthly e-news series by visiting candoms.org. Once again, I wanted to take a brief moment to thank our generous sponsors for supporting this year's webinar series. Thank you to EMD Serono, Genentech, Sanofi, Viatris, and Zenas. And at the end of this program, if you could please stick around and take the survey that will pop up in the conclusion of this webinar. We appreciate everyone being here, and we hope to see you next month as well. And I wanted to say thank you again to both Dr. Pardo and Kristen for being here today. We appreciate all the knowledge that you shared with us, and thank you guys for being here.
Appreciate it. Hope to see you soon.
Yes, thank you. Have a good night.